Good morning. Welcome. My name is Nieves Gonzalo. I'm an interventional cardiologist working in Madrid, Clínico San Carlos, and I have the pleasure of co-chairing this session with Professor Lorenzo Raber from Bern in Switzerland. Yesterday was a very important day for intracoronary imaging. Some of the most important trials performed in the field were presented, adding more data to the already big body of evidence indicating the value of these tools to improve the outcomes of PCI. So in this session today, first we will try to review briefly the data that was presented yesterday, and for that we will have the help of Dr. Mirvat Alasnag for Saudi Arabia. Then we will have a very interesting debate about the different tools we have available, IVUS or OCT, and we will do that with Dr. Ziad from New York and Dr. Daemen from the Thorax Center in Rotterdam. And finally, Dr. Johnson from Bristol in UK will give us a pragmatic approach to OCT through a case presentation. So first, let's start reviewing the data that was presented yesterday. Dr. Alasnag, please.
Well, thank you, everybody. And I was interested in reviewing the data just like everybody else, because really this is what drives our practice and changes. I'm going to go over very quickly the most relevant trials, the October trial, the Illumian 4 trial, and the meta-analysis, the network meta-analysis that was presented by Dr. Greg Stone, just as a segue to what's coming up in the rest of the hour. So we'll start with the October trial, and this was actually already simultaneously published in the New England Journal of Medicine. The premise or the background for this trial is that we need to recognize that bifurcations are associated with worse clinical outcomes, and we have data from both the Syntax trial and the eUltiMaster registry, which were very large patient populations captured, indicating higher mortality rates and event rates in terms of MI, TLR, and stent thrombosis in patients who undergo bifurcations compared with, straightforward lesions. And as such, the October trial was designed. What they did is they took 1,200 patients and randomized them, and the randomization was 1-to-1, where OCT guided stepwise protocol, and I'll show you it in just a moment, and an angiographic guided PCI. Now note that intravascular ultrasound was not advisable. However, the angiography arm, they were allowed to use IVUS if it was a left main intervention. The primary endpoints were major adverse cardiovascular events at 2 years, meaning cardiac death, ischemia-driven target lesion revascularization, and target lesion myocardial infarction. This is the protocol that they adopted, so naturally they could assess the lesion pre-hand, where they define the morphology and define the length and the reference diameters and so on, but they also did post-stent evaluation, where they looked at, after the stenting, they looked at dissections, malappositions, the wiring, whether it was abluminal or not, and wire positioning and so on. And of course, at the end, they did a confirmatory OCT. Now, this is the final result at 2 years, where they ended up enrolling 600 patients in each arm approximately. The average age was about 66, and 21% were women. 14.1% of the angiography-guided PCI arm had an event rate compared with 10.1, and this was statistically significant. Now, these were patients, half of whom had provisional strategy, but DK crush was also equal in number enrolled. So really the conclusion here is that for complex coronary bifurcations, OCT-guided PCI did reduce major adverse cardiac events after 2 years when compared with angiography-guided PCI only. I'm going to move on to the next trial, Illumian 4 trial, and of course the PI is sitting here with us, so we can always address some of the issues. But the background for it is this falls on the backdrop of Illumian 3, and this was the trial that showed us that OCT guidance helped with procedural success, meaning we had better stent expansion compared with angiography guidance, we had less malapposition, dissections that were detected. But whether all this translated into better clinical outcomes was not addressed previously, and this Illumian 4 is considered the largest global trial that actually looked carefully into it in a randomized fashion. So some important definitions is that when we look at high-risk patients, and this was targeting high-risk patients, is that we don't look at the lesion alone. We often think of the lesion in terms of, is it a CTO, multiple lesions, the length of the lesion, and was it a STEMI or a non-STEMI? But just bear in mind that we're also looking at a high-risk patient, meaning diabetic patients on treatment. The endpoints for the trial were a primary imaging endpoint, which was powered, and they looked at post-PCI minimum stent area assessed by OCT, and it was superiority was assessed here. Primary clinical endpoint, again, it was powered, and they looked at target vessel failure during the 2-year follow-up period. Again, superiority of OCT compared with angiography is what they're going to look at. And finally, a safety endpoint looking at stent thrombosis and procedural complications, but this was not powered in Illumian 4. So they started out with just under 2,700 patients from 80 sites across 18 countries, randomized them to OCT guidance versus angiography guidance, and followed up these patients very elegantly that in spite of COVID and everything, they still managed to have at 2 years 94% representation from both arms approximately in the follow-up. So the trial actually ended up including 2,487 patients, about 1,200 in each arm, OCT and angio-guided. The mean age was 65, and 22.6% were women. So a minimum stent area that was achieved was larger in the OCT-guided group, very comparable to the Illumian 3 when compared with the angiography alone, and you can see the numbers there, 5.7 versus 5.3. Target vessel failure within 2 years occurred in approximately 7.4% versus 8.2% in this group, and I'll show you the graphs just momentarily. When we look at the safety endpoints, there were fewer angiographic complications in the OCT-guided group, and there was a larger minimum stent area as expected, which resulted in fewer dissections, malapposition, a tissue protrusion, and untreated reference segments. But stent thrombosis is an important factor, and within 2 years, it occurred in 0.5% of the OCT group and 1.4% of the angiography group. The number of cardiac deaths, MIs, were fewer in the OCT arm, and although these differences didn't really reach statistical significance. So this is what you see. So the table clearly shows you that OCT compared with angiography had bigger lumen achieved with the stent. Target vessel failure overlapped, essentially. And then the complications were significantly less, including stent thrombosis in the OCT arm compared with the angiography alone arm. So really the investigators do tell us that large MSA enhanced safety of the PCI procedure itself, so success of the procedure, with nearly 2/3 reduction in stent thrombosis at 2 years. However, the primary endpoint of this trial was target vessel failure, and at 2 years they were identical in both arms. And finally, moving on to the network meta-analysis, which really brings all the trials together. So this was a real-time updated network analysis, integrating data from the Illumian 4 that we just went through in October with prior studies. And what they wanted to look at is the overall impact of intravascular imaging, meaning IVUS and or OCT, compared with angiography, or IVUS compared to angiography, or OCT compared with angiography, and finally, IVUS versus angiography. So it took about 20 randomized trials that involved intravascular imaging, guided PCI compared with angiography guidance. A total of about 12,500 patients were involved, both those who presented with stable chronic coronary syndromes and those who presented with acute coronary syndromes. And approximately 7,000 were allocated to the intravascular imaging group, 3,000 in the IVUS and 2,800 in the OCT group, and then 5,300 in the angiography-only group, and they were followed up from 6 months and 5 years. So this I take from Davide Capodanno, which effectively shows you the trials that were looked at in this meta-analysis, OCT versus angiography 6, IVUS versus angiography 9, and then OCT or IVUS versus angiography, and so on and so forth. Now, this meta-analysis did not actually include the Octavius trial, which you see in the bottom here. The endpoint was target lesion failure, defined as a composite of cardiac death, target vessel myocardial infarction, and target lesion revascularization. And then the secondary endpoints were cardiac death, target vessel MI, TLR, and stent thrombosis, as well as all-cause death, all-cause MI, and target vessel revascularization. And here are the results. So compared with angiography-guided PCI, any intravascular imaging-guided PCI with OCT or IVUS did reduce target lesion failure by 31%, and ischemia-driven revascularization by 46%, 20%, and 29% respectively, as you see over here. Now, intravascular imaging-guided PCI also reduced stent thrombosis by 52%, all myocardial infarctions 18%, and all-cause death by 25%. The outcomes were similar in OCT-guided PCI and IVUS-guided PCI when compared individually against angiography or against each other. And again, Davide actually did look into this, and he went ahead and added the Octavius in his commentary following the presentation. This is effectively showing you the same thing when you look at network benefit. So it was 31% for all imaging, IVUS versus angio 35%, OCT versus angio 21%, and then OCT versus IVUS, it was kind of no significant addition there. And this is the one where he did end up adding the Octavius to it. So really, to wrap up everything that I just mentioned very quickly so we can just dive right into the debate, is the results of this analysis emphasize the importance of intravascular imaging, whether it is with OCT or IVUS, to optimize your stent outcomes and hopefully improve long-term prognosis of patients. And I'll turn over now to our chairman.
Thank you so much, Mirvat. Thank you so much for summarizing all the accumulated evidence that has been presented only 24 hours ago. I would like to mention that you can actively contribute to this symposium by either standing up and going to the microphone, or online. Please pose any questions that you may have with respect to the presentation. So obviously, let's start with the last part of your presentation. Greg Stone presented a very convincing updated meta-analysis on more than 12,000 patients that have been randomly allocated to either receiving intracoronary imaging versus angio-guided alone. And clearly there have been meta-analyses before that were published, and I think it's noteworthy to mention the new aspect within this updated meta-analysis, which is that there is in this updated one a clear benefit in terms of all-cause mortality, which has not been shown before. Up to date, there was a clear signal for cardiac death, but never for all-cause mortality, with a 25% reduction. And importantly, there was so far only a signal for any myocardial infarction, and in the updated meta-analysis there is a robust point estimate at 0.8, which means a 20% relative risk reduction in terms of MI. Now, I would like to start the discussion by asking the panelists what do they believe how it will impact the current guidelines, current ESC guidelines on myocardial revascularization, to allocate a class of recommendation to the use of imaging-guided PCI in selected patients. And I would like to ask your opinion on how the accumulated data may impact on this evaluation of the evidence. So, Mirvat, do you want to give your...
Yeah, so the current guidelines that were just elaborated here at ESC 23 actually do make very specific recommendations in the acute coronary syndrome guidelines to use intracoronary imaging, IVUS or OCT, for patients with a defined culprit. And for those with an ambiguous culprit, where the culprit has not been identified, they actually assign a class 2B to use intracoronary imaging, between parentheses, with preference of using OCT, just so that you can see a little bit more. I think revision of these guidelines may come into play, where we recommend using them even outside the setting of acute coronary syndrome and the chronic coronary syndrome, because that's what the data is showing as well.
This was what I was actually alluding to, the coronary revas guidelines, not the ACS guidelines. Obviously also a 2A in the ACS guidelines, but the large patient population that we treat are indeed CCS patients. So, and Joost, how do you see this situation?
Well, I think this clear reduction now in all-cause mortality based on a series of, I think, 13 randomized control trials proving the superiority of imaging-guided PCI cannot be ignored. And I attest to the fact that most of these trials were initially derived from Asian populations. Now we have actually 2 global trials that added to this equation, which also makes these data, which were gathered up until this far, likely more applicable also to Western populations. Most of these trials, though, were performed in patients with higher risk patient and lesion subsets, either those with ACS, left mains, instant restenosis, long lesions, and so on. But I think particularly to these patients, I do hope and I do expect that guidelines will change and will start to change the recommendation for the use of imaging, particularly for these type of patients.
Thank you very much, Joost. I think you made an important point. To which patients do these data apply? Certainly not to type A lesions, but rather to complex lesions with lesion length probably above 30 millimeters, CTOs and bifurcation lesions. I think we have questions from the online audience.
Yeah, so some colleagues from the online audience are asking about the use of imaging in the context of left main, specifically IVUS, and especially in the context of primary PCI. So the combination of 2 recommendations that are currently now in the guidelines, STEMI plus left main. How do you see this, the use of IVUS in the context of primary PCI and left main? Joost.
So let me repeat the question. So the question is whether or not we would like to change our thought on the use of imaging in patients with left main and acute coronary syndrome. Is that correct?
Yeah, that's right. What one colleague is asking. Yeah,
so that's a good question. So obviously there have been dedicated trials in left main, particularly referring to IVUS. The Optimal trial is likely a very important trial that addresses this issue particularly. ICRI trial just finished enrollment a couple of months ago. We do expect the results somewhere in the upcoming year. So that trial will definitely partly answer the question, particularly for patients presenting with stable angina. But per current guidelines, I do believe that the use of particularly IVUS has been established in the treatment of left main disease. Left main lesions typically refer to bifurcation lesions, and in that particular aspect, I think the October trial only added to that equation, attesting to the fact that also for OCT, if you have non-osteal left mains, this technique could be a very well-defined tool to help us to optimize treatment of left main lesions as well, and thereby absolutely ending up with superior outcomes.
We are a panel of believers, but I think we can be even more enthusiastic from where we are today from both the ESC and earlier in the year with Renovate PCI. And actually by this interesting issue around complexity of patient cohorts, there was actually a signal that worried me a little from Renovate, which was left main being useful with imaging, but true bifurcation, non-left main, maybe not. And we now have October, and we have a body of evidence that's supporting imaging. We're not talking OCT or IVUS. We're talking about imaging as a concept in terms of guidance of PCI. And with that now, we have the most incredibly robust data to confirm all-cause mortality reduction, cardiac death, TVF. We're now in a much better place. It's not why should we use imaging, it's why shouldn't we use imaging, in my personal opinion.
So you mentioned the October trial, which convincingly showed superiority of OCT-guided PCI in a highly complex lesion subset of left main and bifurcation. What do you believe has contributed to the superior outcome? I mean, it's very notable that the individual components all tended in the direction of benefit of OCT, including all-cause mortality, cardiac death, MI, and TLR. What do you believe is the important addition by the OCT? Which steps are crucial?
Well, that discussion was brought up yesterday, and one of the audience in relation to the Meet the Trialists asked, could we get away with not doing pre-stenting OCT? The reality is that it's acknowledging every step that becomes important. it is assessing the morphology with the pre and making an appropriate assessment of measurement of size, caliber discrepancy, particularly with with left main intervention. If necessary, with calcium, further imaging to assess calcium modification. Then following the stenting to ensure that we have adequate optimization. I mean, the October protocol, as Mirvat alluded to, was highly complicated, and I'll touch upon that in my presentation, but steps in terms of abluminal wiring, effective pot, a whole host of other elements to what are really challenging techniques that we as a community have to accept carry a risk. And so using imaging to diminish that risk and achieve the best outcome for our patients has to be the right thing.
Okay, thank you so much. We all are aware that we have mainly two techniques in the cath lab that we can apply, either IVUS and OCT, and there are many similarities but also differences. And within the next 10 minutes, we would like to get a flavor of which might be the differences, whether they are relevant or not, whether they are complementary or not, and if to which degree. And for that purpose, I like to ask Ali Ziad to make the case for OCT.
I think it's Joost first.
You changed the role. No, Joost Daemen will start with making the case for IVUS. Thank you, Joost.
Okay, we'll start with making the case for IVUS, but honestly, I think we again need to make the case for imaging and not necessarily for one technique versus the other. But what I want to try to do is in the next 5 to 10 minutes at least to give you a little bit of a flavor what IVUS is, what the evidence is about, and why we think it's a proper technology for a wide range of patients that can help you to get better outcome. While doing that, I would like to start, following the extensive presentation of Mirvat on the data already, is that these data actually yesterday did not really come as a surprise, because we knew, as of already 2020, this is just one of the many meta-analyses that have been published on the topic, that the vast majority of data supporting the concept of imaging-guided PCI has been related to studies studying the effect of IVUS-guided PCI. This is just a pooled data set, over 27,000 patients, 9 randomized controlled trials, 10 observational studies, already attesting to the fact that IVUS-guided PCI decreased the risk of cardiovascular death by 33%, MI 39%, TLR 19%, and also stent thrombosis with 43%. So that, I think, attests to a robust body of evidence which was already available since several years, showing us that IVUS-guided PCI, what has to be said, mainly in more complex patient subsets, was able to help us to improve patient outcomes. Those were results up to 1 to 2 years, but these findings have been extended up to 5 years. And this is important because we learned that IVUS-guided PCI results that were superior at 1 year were durable, with sustained improved outcomes up to 5 years. Here, just some results from the IVUS XPL and Ultimate trials, some of the larger randomized trials on the topic, helping us to understand that the benefit of imaging-guided PCI, IVUS in particular, was sustained up to 5 years. So what about, and that's a little bit to the question we had just a few moments ago, what about the impact of IVUS-guided PCI in ACS? This is obviously one field that is still maybe a little bit open for debate, depending on how you define ACS. For STEMI, there are no dedicated randomized controls trials yet, but in patients with ACS in general, there is accumulative data, in this case, over 800,000 patients, mostly registry-based, by the way, that helped us to understand that IVUS-guided PCI showed a strong trend and actually a significant improvement, in this case in all-cause mortality in patients presenting with ACS. So that's what we knew as of earlier this year when we pulled all data on IVUS-guided PCI in patients presenting with ACS. And that's where I think yesterday's data was incredibly helpful in helping us to understand that when pooling all the data we just saw from the IVUS data, now also adding October and Illumian 4 to the equation, that not just imaging is able to reduce cardiovascular death, but even all-cause mortality with a relative risk of 0.75, so meaning a significant 25% reduction in all-cause mortality when imaging-guided PCI was performed. Second part of the presentation I wanted to share with you is the fact that I believe that imaging per se will not improve patient outcome. It's the fact that you need to pay attention to how you use the imaging in 3 stages throughout the procedure. And whether you call that the IVUS 1, 2, 3 essential protocol, MLD Max, or any other protocol that may be introduced in the near future, it's basically all about the same thing. First, you start off with pre-PCI imaging in order to assess lesion severity and plaque morphology. Second, you perform pre-stent imaging to assess whether your potential, if any, plaque modification was efficacious, and you determine the stent size, and finally you end with post-PCI imaging to attest to the fact that your PCI achieved a result that was as optimal as possible. And the relevance of the latter was illustrated in several of the previous IVUS trials, but this is just an example of Renovate, showing you that your event rate up to 3 years was 12% in the angio-guided arm, whereas in patients that achieved an optimal imaging result, event rates were less than half. Whereas in patients in which imaging was used but no optimal result was achieved, event rates were 9%. So this just to say that imaging per se will not help you to get better outcome. You really need to try to get an optimal result, and that also illustrates the efficacy of the, for instance, October protocol that was very stringent in forcing the operators really to get an excellent result. Here are just a couple of imaging examples to put those results a little bit more into a pragmatic fashion. Pre-PCI imaging, the key thing is that you start with assessing lesion severity. That's the basic concept of the first pullback you do. And that's where IVUS is a very easy tool to help you to understand the presence of calcium, which is likely the most important thing in achieving optimal stent expansion. On the left side here, a clear example of a lesion with a lumen area of 1.9, which is clearly insufficient, but more importantly, almost 360 degrees of calcium, which is very easily recognizable on the IVUS, attesting to the fact that this is not a lesion that you want to stent immediately. That's where the IVUS can help you to direct the type of lesion modification you want to do. In this case, we just took a trio non-compliant balloon in order to see if we could fracture the calcium. In this case, the IVUS was repeated. That's critical. If you do lesion preparation, you repeat the imaging. And that's, again, a big advantage of IVUS. There's no need for contrast, so that will not come at any price in terms of contrast load. You repeat the imaging and attest to the fact that the calcium in this case is fractured and this lesion can be stented. Only then you use, during the same pullback, the data to help you define a landing zone and size your stent. I will not dwell into all of the individual stent sizing algorithms, but what is critical to understand is that you learn to recognize what is healthy, as shown here on the left side, a healthy artery and IVUS, versus what is diseased. IVUS will show you the lumen, but IVUS will also show you the full vessel, which makes IVUS an excellent tool, due to its larger penetration depth, to not just see the lumen, but also see the full vessel. And you will be able to recognize, without doing any measurement, that the image here in the middle is a vessel with a significant plaque burden that should not be a landing zone for a stent, irrespective of the fact that the lumen area might be 6 here. In that case, you use the IVUS tools to find a landing spot that has a plaque burden less than 50%, and that is critical. If you use IVUS, pick a landing zone with a plaque burden less than 50%. Finally, your post-PCI imaging. 3 things are important. 1, minimal stent area. Minimal stent area, in this case 6.1. So we use the cutoff of 5. In all previous IVUS studies, everything above 5 was good and associated with better outcome. In this case 6.1, so we put that in green. MSA larger than 5 looks significant, or at least appropriate. In this case, this was the distal edge. Lumen area 5.9, you would say, well, that's not too bad if the area in the stent is 6.1, but the plaque burden here was way above 50%. So this was not an appropriate landing zone. And again, also IVUS with the particular newer techniques, high definition IVUS also allow you to see dissections. Obviously, smaller dissections with IVUS much more difficult to see as with OCT. However, they are visible in case they are relevant for somebody who's used to use the technology. Then what about stent expansion? I'm showing you this simply because of the fact that if you would calculate stent expansion, and with IVUS, you need to calculate it yourself, and that's the big advantage of OCT, but you need to be able to interpret the figures. If you computate, in this case, stent expansion based on the distal reference, you would calculate 103% because the distal lumen area is 5.9, minimal stent area is 6.1. That's 103% stent expansion. You would say, well, that's good. Well, actually, I've just shown you this is not good. This is not optimal stenting because the stent ended in the middle of a plaque with a plaque burden above 50%. And that is something we routinely see, and that is something that has been shown to be a strong predictor of future target vessel revascularization. Finally, the relevance of this minimal stent area, I already alluded to the fact that in previous data, the minimal stent area above 5 is a strong predictor of proper outcome and significantly lower event rates as compared to patients with a minimal stent area below 5. And then finally, what I wanted to show you is how does that correlate to OCT. These are the results of the Illumian trial on the left. So if you look at the minimal stent area post optimal PCI in Illumian with OCT guidance 5.7 versus angio-guided 5.3, which was statistically better. But now take Octavius, a identical final minimal stent area with OCT 5.6. However, with IVUS, the operators for some reason were able to get better outcome with a final minimal stent area of 6.7. Whether this is truly relevant and will apply to the potential differences between the IVUS and OCT trials remains to be determined. What is important to realize is that Illumian was the first really large-scale randomized global trial, whereas Octavius, as well as most of the other IVUS evidence, was derived from Asian populations. So for those people who are still not convinced, I think it's important to highlight there are 4 large randomized controlled trials on the way. There is Optimal, a particular trial on left main guided PCI with IVUS. There is IVUS CHIP, a large European randomized controlled trial, over 2,000 patients in which we just finished enrollment. Events are hopefully to be presented by the end of next year, IVUS and high-risk PCI. iSTEMI for IVUS and STEMI, and improve the US and now also global variant of a high-risk patient study with IVUS-guided PCI versus angio-guided PCI. With that, I would like to conclude, and thank you for your attention.
Thank you so much. You highlighted the potential differences between techniques, the lack of, you don't need contrast, you see deep in the vessel wall, the EEM, and the calcium, the imaging of calcium is straightforward. So which could be the potential benefits of OCT? How does it differ as compared to IVUS?
So thank you very much, and I want to thank Joost for proving my point that nobody can interpret an IVUS image. That's the problem. It's too hard to understand IVUS. And unless you have a Kiko in your lab and you'd use IVUS on every single case, you will miss these findings. Now, how can this make sense? How can a lower resolution device give you a better outcome than a higher resolution device? How can that be biologically plausible? Let's think about this. So, as Joost said, whatever algorithm you're going to use, whether it's NLD max or 1, 2, 3, these are the things that impact PCI. The morphology, the length, you got to go normal to normal, but you got to find normal to normal. Dissections, to treat a dissection, you got to see it. And then afterwards, you want to be able to make sure that the stent is opposed, so you got to be able to see the struts, and you want to make sure that you can measure the expansion without needing a PhD in mathematics. In order to integrate intravascular imaging into PCI, it has to be simple. That's why we made NLD Max, so you can remember it and apply it. So let's start with morphology. Okay? We made NLD Max simple for everybody to follow. Morphology. This is the simplest I could make IVUS interpretation. And I really tried. Okay? And what it includes is hypoechoic, hyperechoic, shadowing, whether there's a wall, but I'm the first to admit this is still hard. It is very hard to differentiate a hypoechoic from a hyperechoic lesion where the shadow is. Let's look at OCT. It's simple. You can see it, All you need to know is, can you see the circle around the vessel? If the circle's there, the artery's normal. If the circle's not, there's a problem. If it's in the wall, it's lipid. If it's diffuse, if it's well circumscribed, it's calcium. If it's in the lumen, it's thrombus or it's tissue protrusion. Simple. Now, Joost was the first to admit that the thing that we care about most for plaque preparation is calcium. Well, these are two exactly the same lesions. Nobody can tell me how thick that calcified plaque is by IVUS. It's impossible. But by OCT, I know exactly how thick it is. And we know that the arc, the depth, and the length of the calcium is an independent predictor of stent expansion. Check OCT. What about the morphologies, right? We want to know the different types of calcium morphologies because calcified nodules, whether they're eruptive or non-eruptive, are different. Sheet calcium is different from thick calcium, protruding, etc., etc. So on calcium morphologies by OCT can easily be determined and clinically actionable. But the fact is, it's just harder to do that with IVUS. Right? It's hard to see exactly where this calcium is, and as a result, it's harder to know whether or not I've modified it. Now, let's say we do modify it. What do you want to know? You want to know whether or not you fractured it. Okay, so on one side you see IVUS fracture. So you got to sneak around the lumen to look for this acoustic shadow that bounces around behind the wall. But with OCT, it couldn't be clearer. The fractures have a box pattern. They're really simple to see. Okay, so morphology, OCT. Now length, we basically use the same strategies. We use the longitudinal pullback. We try to find reference segments of the artery that look normal. If we do, we put a bookmark. If they don't look normal, we scroll around to try to find a segment of the artery that has a less than 50% plaque burden, and that gives us our normal to normal. Good. You do exactly the same thing with OCT. You try to find segments of the artery that are normal, but it's easier to see what's normal because if you can see the circle, the EL around the artery's normal or fibrous and you can land your stent there. It's easier to see the disease where you shouldn't land the stent. And as a result, what it does is it streamlines your procedure, and finding the EL is a safety net because if you can see the EL, the artery is a safe place to land your stent. And I don't have to measure the plaque burden by creating a bunch of circles. Ultrasound 1.0 and 2.0 find the EL for you. They make it easy. What about diameter? So when we measure diameter, we use a similar strategy. What we try to do is we look at our proximal and distal references just like we did on the length, but on one side we have to measure the plaque burden, like I said. And you have to do a sort of a calculation to make sure it's less than 50 or more than 50, whether you should use the media or the lumen. OCT simple. You see the external elastic lamina, you use the vessel measurement. You can't see the external elastic lamina, you use the lumen measurement. Lumen and upsize, EEL and downsize. Simplified algorithm. Now, one of the things that Joost said was very important, and it caught my attention. He showed in Octavius that the minimal lumen area by IVUS was a lot bigger. Well, of course it is, because IVUS oversizes by 10%. So just multiply that number by 0.90, and guess what? The numbers are exactly the same. So if you're not playing on the same playing field because of your scale, it's not fair. And that's why in Illumian 3, we gave everybody a blinded OCT at the end. And then we could compare apples to apples. And what did we find? Absolutely no difference. And here's the data, right? So IVUS, 40 megahertz IVUS oversizes your stent by 1/4 size. So it makes you put in a bigger stent. As soon as we did Illumian 3, we dropped that down and we found out it was no longer significant. So let's compare apples to apples, right? Apples to apples would be 60 megahertz IVUS against OCT. In all fairness, they have very similar measurements. We'll accept that. But most of the world is using 40 megahertz or even 20 megahertz IVUS. So how can you make measurements that don't actually equate to what you measured? 2 slides ago, I showed you the IVUS XPL data, which shows that OCT is extremely accurate compared to a phantom model. It means you buy a straw from McDonald's, it's 3 millimeters in diameter, and OCT will tell you it's 3 millimeters. But the IVUS might tell you it's 2.9 or 3.1 or 3.05 because all the crystals are different. We do agree that HD IVUS is the comparator to really compare apples to apples in contemporary PCI. If you want to be using high-resolution modality, let's make it a fair example. What about co-registration? Let's look at co-registration. Let's look at the difference between performing a co-registration between these two modalities. The only co-registration system available for IVUS commercially is 20 megahertz IVUS, right? That doesn't help you co-register. OCT allows you to look at the artery from the inside out and the outside in, and it reduces your geographic miss to less than 0.2 millimeters. What about our post-PCI for a medial dissection? Well, let's see how we measure a post-PCI dissection on IVUS. What we've got to do is we've got to find the edge of the stent. It's grayscale, and I've done several thousand IVUS, but look at that shadow. Is that plaque or is it a dissection? What about proximally? Is there a dissection there? Now, not everybody has a Kiko in their lab. Remember, this is sitting like 12 feet away from you or 6 feet away from you for you to make the decision. Let's find the same example and do it by OCT. The stent is already highlighted. You click your button, you look at the edge, the resolution is excellent, you can quickly determine whether or not there is a dissection. So the speed by which you can do your post-PCI optimization is meaningful. What about apposition? So we care about apposition, and the way we got to do it by IVUS is we have to do it manually. By the way, these are exactly the same case. These are co-registered images. So now I got to scroll through the artery, but every time there's plaque behind my IVUS image, I can't tell whether the stret's opposed because I don't know if it's lipid or I don't know if it's space. Right? So I'm guessing. Isn't the whole point of intravascular imaging to eliminate guessing? So there's too much guessing related with this technology. Let's look at OCT. OCT tells you everything on one slice. The white bar tells you it's fully opposed. Let's move on. 5 seconds or less. And then we've got to do expansion, right? So when we do expansion, let's do an expansion in real time. So this is where you can, get your PhD in mathematics. I don't think interventional cardiologists want to be doing math during the case, right? This is a real caveat. And so what I'm doing here is I'm measuring the distal reference, and now I have to manually scroll through the artery and find the MSA. Isn't the whole problem in human error that Nick West is going to pick a different cross-section than I am, and Joost is going to pick a different cross-section, and then Nieves is going to pick a different cross-section? So what was supposed to be quantifiable and actionable has now become completely subjective. But what if we do the same thing, right, by OCT? The exact same assessment. So here we see 90% expansion. The OCT just puts it on the screen for you. It does all the math for you. 92%. I don't need to do any more. So you can see in totality, I did the medial dissection, the apposition, and expansion in less than 20 seconds. So this is how you streamline procedures. Now, in all fairness, these are two modalities which are very similar but do have some features which allow us, just like a Swiss Army knife, to use the right thing in the right situation. Okay? Lorenzo and Tom, both first authors of the consensus document, which have provided tremendous impact to the field, have said this and said, these overall do the same thing. We need to get good at them. If you're good at only one, that's okay. If you have both, get good at them. And they provide the same clinical impact. But there are some subtleties. And I think these are my opinion, but they're fair. The PCI guidance with OCT is faster, easier, less subjective, and more automated. And now with artificial intelligence, that becomes even easier. But there are certain situations where we have to admit that IVUS is superior. Like in chronic total occlusions, where we don't want to dissect the artery with a hydraulic dissection. In the left main, maybe not the distal left main, but it's certainly in the proximal or ostial left main, where we need to make sure we have coverage. Ostial lesions, we couldn't include those in Illumian 3 because we can't see them. And there was a big benefit in Renovate PCI in ostial lesions. And finally, in advanced chronic kidney disease, while we're getting there with non-contrast flush solutions, it's not the same as not using any contrast. Thank you so much.
Thank you, Ziad and Joost. So I think after your presentations, it's clear that the general idea is imaging is beneficial for patients. Both techniques can be used in most patients, and there are some specific situations where one might have advantage over the other. So, Ziad, there are some questions from the colleagues here about Illumin 4. And of course, we have seen the two techniques really give us very similar information. So we should expect differences in the results in trials. And of course, some people are puzzled about the results of Illumin 4 regarding clinical events. And would you like to give some explanation? Because, of course, we were very surprised to see these very low rates of TLR. What are your interpretation of these results?
So a couple of things that we did when we did the deep dive. So obviously, as an investigator, I was disappointed to find that the primary clinical endpoint was neutral. That's natural. But the scientist requires us to dissect out why and what happened. What did we learn? We learned that target vessel myocardial infarction and cardiac death, real events that happen to people, they're almost exactly the same hazard ratio as Ultimate, XPL, and Renovate. So what's different is TLR. Now, usually TLR rates are high, and the difference or delta in the TLR is what drives the hazard ratios and the p-value. Before COVID, when we had a one-year follow-up on pre-COVID patients, we had the hazard ratios exactly where we anticipated, 0.70 favoring OCT. Now, what happened, and I learned this along the way, is that revascularization is a choice. It's not an event. So if you have recurrent angina, you have to choose to go to the hospital where there's a lethal virus or deal with your angina at home. Many patients would say, I'm okay. Those same patients would have their medication up-titrated, learn that their angina is not going to kill them, and manage it. And what ends up happening in that situation is you bias towards the mean. The second thing that we saw, which was quite an interesting phenomena, is that the angio arm in the Illumin 4, the operators did an incredible job. I mean, they used huge stents, huge balloons, post-dilated at almost 20 atmospheres, which is unparalleled for any study we've seen before. And all of us know that there's this sort of crossover point somewhere between 4.5 millimeters squared and 5.4 millimeters squared, where there's the biggest delta where we can give the benefit. Doctor studies showed us that more than 5.4, you have an FFR greater than 0.90. Multiple studies have shown greater than 4.5 by OCT. You do very, very well. And since our mean MSA in the angio arm was above that, the magnitude of delta of that increase in MSA got contracted. And so those are the two primary explanations for why IDTLR is not different. Those are not excuses. That's the data. We agree with it. We believe Illumin 4 was an incredibly conducted trial, and that's what it is. But we also have to accept what we found in terms of stent thrombosis, which is incredibly meaningful. A 66% reduction in the most catastrophic event. Like, I get upset when my patient gets a TLR when I heard they come back and they have restenosis. I can't sleep when they get a stent thrombosis, right? It impacts the patient tremendously. It impacts the doctor tremendously. So those are some of the take-home messages and the nuances that we're learning about the findings from Illumin 4.
Thank you so much for shedding some light on the potential discrepancy among trials. And I'd like to ask now Tom Johnson to get to the podium. He has prepared a case that was treated along the October trial, and I think it's important for you to understand the complexity of the treatment protocol that led to these positive results. Thank you so much.
Thanks, Lawrence. I'm a proud Brit, and I have to say I thought the Brits were good at debating, but Joost, I'd just like to say I think it's about imaging, not about a battle between OCT and IVUS. So I use both technologies. So thank you for this. These are my conflicts. My presentation is easy, really, because it's to reflect upon October and to use a case to really show to you how the operators, the participants in the study, went about comparing an angio-guided approach to bifurcation PCI and an OCT-guided approach. And we've already seen this Kaplan-Meier plot showed by Mirvat. Now, the interesting thing here was that I'm sure many of you may have had WhatsApp communication going in a frenzied way yesterday morning with the results of all of these studies. And these were the sorts of things we were hearing. Well, high number of early events on these Kaplan-Meier plots, immediate separation of the curves. This seems dodgy. There was a question actually yesterday afternoon in the investigators. Could the differences in stent technique between the two arms actually drive differences we see clinically? So you have to understand that all the data isn't necessarily apparent in the New England Journal, so these Kaplan-Meier plots for the individual secondary components aren't evident. But what you can see here is that actually the primary endpoint is profoundly driven in the early part by target lesion myocardial infarction. And so that concern about that very marked elevation in events early around the time of procedure has to be acknowledged. But actually, if we look at contemporary bifurcation studies, such as the Definition 2 study, which was a comparison of provisional against two stenting techniques in the most expert Chinese hands, we actually see a very similar hazard in that early phase. This is a Kaplan-Meier plot for me that I would challenge. How we see such huge hazard with the simple provisional against a complex two-stent, I don't know. So the next part of that question or challenge from yesterday was about stenting techniques. And again, in the supplementary appendices, you can see that actually the operators of October undertook a huge amount of highly complex intervention. So almost 2/3 of the intervention was two-stent technique. And in line with the European practice, we see a majority of culotte, but actually fairly well balanced between culotte and DK crush as the preferred strategies in two-stent technique. So I was tasked with sharing an October study case, challenging when you didn't participate. I was on the DSMB, but I didn't recruit patients. So I turned to a good friend and colleague, Peter O'Kane, from Bournemouth in the UK, to look at one of his cases. So this was a patient randomized to OCT with, I think you'll agree, highly challenging left main stem Medina 111 disease. We've talked about, both with IVUS and OCT, this importance of pre, peri, and post-procedural imaging. Now, clearly, actually delivering a device with such complex disease is not possible. So the calcium is identified, an upfront technique of rotablation is taken. Peter adopts a kissing balloon for further predilatation. And then most importantly undertakes, as per protocol, imaging of the LAD and the circumflex. And actually here acknowledges still an incredibly high burden of calcium, for which he then actually takes additional adjunctive technology. So we see here then IVL taken, but most importantly, as highlighted by both debaters, this need to then take further imaging to be sure that that adjunctive technology has done what we needed it to do. And so we see in this short clip of OCT actually more aggressive injury and fracture of that calcium, enabling then the confidence of moving forwards to stenting. So here stenting the circumflex with a balloon to crush the device in the LAD, rewiring, and then another step of OCT to ensure an adequate cross. And I have to say, this is challenging even for people using this technology on a daily basis. It can be difficult. Peter highlights where the wire is crossing here. There is obviously the ability with the AptiView software to use three-dimensional rendering, which will come back into Ultron 2.0. But even here, actually, this is me and my colleague Sean Gallagher in Cardiff, kind of having to question and challenge exactly where this wire crosses. So the technology is good, but it still can be quite challenging. But having established where that wire's crossed, then you can move forwards, perform the first kiss, deploy the stent into the main vessel, undertake a pot, and then recross, and again undertake another OCT down now the LAD establishing whether the wire is mid-proximal in terms of optimizing that subsequent second kiss of the DK crush technique. Here we see then the 3-5 balloons going up in the LAD and circumflex, a further 5-0 pot, and then very importantly, the runs in the LAD and the circumflex confirm optimization. So in total, Peter, in this true October study case, has undertaken 6 runs. But I hope you all agree that a hugely complex technique of DK crush has been done with the most incredible expertise and confidence on the back of the fact that the imaging has been used throughout the procedure. So a pragmatic approach to OCT has to be image guidance, not optimization. We use it at the beginning, we use it in the middle, we use it at the end of the procedure. Ziad emphasized repeatedly easy. I would challenge him. What we do is difficult, and we have to acknowledge that the interpretation, the techniques we adopt for our patients are difficult and they carry hazard. It's right that we should be seeking easy support, but never forget the hazard that we're placing our patients at with the techniques that we undertake. October has undoubtedly confirmed superiority in my mind of an image-guided approach against angiography, and it will be interesting to see how at the European Bifurcation Club that falls out. OCT guidance requires engagement, as I hope I've emphasized to you, with the images. Before, as Ziad nicely delineated in terms of identifying morphology, sizing the vessel, during the procedure in view of these technical complexities, particularly with bifurcation disease, and then afterwards in terms of acute optimization. But as I said, I think the mission, to improve our patient outcome doesn't end here. There is more we can still do. Thanks for your attention.
Thank you, Tom. And actually, I think you have just answered one of the questions here from our colleagues. Some of them are asking which steps of all these in the middle, post, which steps do we think are essential, are really impacting outcomes? Do you think is there any step that we can skip? Is the whole procedure? And also about optimization, I mean, there are some criteria, but this cannot achieve in some cases. What we need to do is the best that we can achieve in this specific patient. What is your take on that?
So I think, speaking for Niels and Lena, who presented yesterday, there's a huge amount of data that has been accrued through this incredible study that as yet hasn't been formally assessed. For me, and I think from what I've heard from the debate, the agreement would be that I think identifying the complexity of disease and ensuring that you modify it, assessing the appropriate sizing, which can be challenging. You take a 2.5 stent that actually needs to go to 5 millimeters in the left main. We have made the mistake. The issues around wire cross, all those other elements, I think are harder and more challenging. So the focus for me would be on identification, morphology and sizing, this MLD element of the algorithm, and then the optimization in terms of expansion malapposition, which is often much more frequently seen and potentially relevant as we see that early hazard in all bifurcation studies. And so, again, the resolution of OCT here, in my mind, is a definite benefit.
Thank you so much. So, overall, it has been a fascinating ESC with respect to intracoronary imaging. We now have evidence, and very robust evidence, that overall imaging is reducing hard outcomes, including death and myocardial infarction, as well as TLR. There were important trials that have been released, like the Renovate PCI that showed superiority, the October that showed superiority, and the iLumin that was superior in terms of MSA, but failed the primary clinical endpoint. Clearly, we are looking forward to further analysis in this regard to fully understand which explanation may apply to understand the differences that were probably eventually present in these trial. But again, overall, the accumulated evidence may lead to a guideline change very soon and has clearly impact on our clinical practice. I mean, DES technology has clearly reached its climax. It's difficult to be better than current drug-eluting stents. And if we want to further improve the outcome of our patient, I think what we need is a perfect result, and the best way to get there is clearly intracoronary imaging. And an important note is that if you regard the different treatment protocols that were applied in all those studies, what is required is training. It's not self-understood how to apply imaging in clinical routine practice, but I think it's very important really to translate these successful treatment protocols into clinical practice, and this needs education and training. And I think that's what we're going to do all once back home. We look forward to the next years, because many data is accumulating and will be presented soon, so the journey will be a fantastic one. Thank you so much for attending this symposium.